Good morning, everybody. Today, I'd like to share with you a new paradigm, actually a paradigm shift. This is a paradigm which is restorative radiofrequency therapy. This therapy addresses the structural component of erectile rigidity, specifically the tunica albuginea and the veno-occlusive mechanism. For decades, we have now been focusing on vascular inflow. These current treatments that you've heard about really treat this vascular inflow. They are quite effective, but they are symptomatic. They are also temporarily. Their effect is per sexual act only, and they do not treat the main root cause of erectile dysfunction. Recently, we've explored biological signaling. The stem cell therapy, PRP, all signal cells to improve their function by bioactive molecules like VEGF, nitric oxide, and cytokines to improve their function and to improve the tissue function. But unfortunately, they still remain a bit inconclusive. The success rate is 70%. Their durability is questionable. They still have limitations, and they are mainly considered experimental. So the missing component in ED therapy has been structural restoration. Clearly, erectile function and erectile rigidity depend on the tunica albuginea and its biomechanical competence. The question is, are we doing anything to confront this? Well, RF has been used for decades in dermatology and orthopedics, and this does induce tissue remodeling and regeneration. Radiofrequency is an electromagnetic wave with a sinusoidal wave that oscillates polar molecules, mainly water, and this oscillation and friction causes heat. Now, the oscillation actually generates controlled volumetric heating from the inside outward. And this is critical because the heating is uniform and intrinsic to the tissue. So thermal stress activates heat stress proteins and fibroblasts and induces neocollagenesis and collagen remodeling. What you see here is a picroserous red staining of collagen viewed under polarized light. As you can see, RF energy induces progressive collagen thickening, alignment, and maturation. These are all hallmarks of neocollagenesis and structural reorganization. The tunica albuginea is composed 95% of collagen. Collagen is a triple helix protein that is remarkable with flexibility and strength. Unfortunately, beginning at the age of 24, there's a decline in the collagen, about 2-3% a year. It fragments with age, and spatial organization of collagen decreases. And in aged or diseased tunica, fibers become fragmented, disorganized, and reduced in quantity, compromising venous occlusion. RF therapy delivers controlled, volumetric, thermal energy, leading to collagen synthesis and remodeling, and results in structural realignment and in architectural repair of the tissue. So, as you can see on the right side, here, this is an electron scan of the tunica, and you can see the bundles and the disorganized tissue of the tunica when it's aged. When applying RF energy, it introduces actually a restorative model. It targets the veno-occlusive dysfunction by restoring the tunica albuginea, and you can see how the tunica should look like. It's wavy, it's organized, and it is thick And this has properties for venous occlusion, as opposed the aged one is venous leak. The collagen is not only in the tunica albuginea. The collagen is also in the extracellular matrix of the connective tissue. And this is very important. About 30 to 45% of it is in the corpora. And the corpora needs to be compliant. And if the collagen is not there, the tunica is not compliant. It is also in the corpora and constructs the intracorporeal pillars, which are mainly from collagen. And it's very important because if the corpora is non-compliant and the scaffold, meaning the pillars and the tunica, are compromised, then the ability to expand as well as rigidity are compromised. Therefore, there's a structural basis of erectile function and erectile rigidity. So the first question we asked when we thought about this is, could applying RF therapy to the penis lead to clinically significant improvement in erectile dysfunction? So we designed two studies, one pilot study and one much more rigorous study with randomized controlled study. So our results from the study of the pilot on 28 patients showed us some very good results, and I'll show you in a minute. It was structured as 8 treatments for the first month and 4 more treatments for the second month, all together 12 treatments in 2 months. And we examined the results 1 month after treatment. The randomized controlled study has more or less the same protocol, but of course it's sham controlled, and it is in 5 medical centers in the United States, including more than 180 patients. This study is already on the final stage of its trial. What we saw in the first study, the pilot study, was an amazing result of 85% improvement in erectile function. There was an increase in 7.6 in the IIF-EF score, and 50% of the patients were normalized, meaning they increased to 25 points in the IIF and above. What was very important to see and interesting is the EHF shift. From 54% of the patients at baseline that were unable to penetrate, 1 month after treatment, 96% could penetrate. And this really suggests a structural improvement. So something is really happening here. These are the final results, as you can see. 80% satisfaction rate, 30% reported return of morning erections. There were no adverse events, which is very important. But something here was a bit fishy because collagen restoration takes about 12 weeks minimum, 3 months. But we achieved responses already after 2 weeks. So what's happening here? We needed to investigate what's going on. The reported results after 2 weeks were morning erections that appeared, improvement in erectile function, engorgement. So we needed to investigate additional biological pathways known to be activated by controlled thermal heating. So what you see here is these proposed mechanisms of radiofrequency therapy: vasodilation, endothelial repair, metabolic remodeling, antioxidant defense, structural remodeling, as we mentioned before, and neural regeneration. All these multifactorial mechanisms underscore the multifactorial basis of tissue restoration and functional improvement. So if we look at it a bit more closely, there's a thermal direct effect. This is because it's heat, and heat causes vasodilation, heat causes the oxygen perfusion, heat causes oxygen entering the cells, and the tension of oxygen increases, and there's oxygen availability for nitric oxide to be produced. There's direct thermal effect also on the smooth muscle cells. They are relaxed when you heat them. And there's also acute effect. Heat activates TRPV channels. That causes the calcium influx and immediately activates enos. And the enos is also stabilized by heat shock proteins that phosphorylate enos. So the outcome is immediate nitric oxide release and smooth muscle cell relaxation. Of course, this improves the oxygenation and the oxygen-induced fibrosis that is associated with it. The heating also does two other things, two other molecular pathways. It increases VGEF and increases FGF2. What do these do? These molecules promote angiogenesis, restore endothelial integrity, and improve microvascular density. That's the VGF. The FGF2, as we know, activates fibroblasts. In this case, the collagen is needed for the arterial wall, and the function of FGF2 in this stage is to stabilize the product of VEGF, meaning ensuring that new blood vessels are mature, they're non-leaky, and NO productive. Of course, FGF2 is particularly relevant for tunical remodeling and compliance. So we get an early vascular benefit, good new neovascularization with good vessels, and late structural rebuilding. So heating not only does this, heating activates the NRF2 factor, which is the master regulator of oxygenation. NRF2 translocates to the nucleus and upregulates more than 200 antioxidant enzymes. The main ones, the important ones, are glutathione synthesizing enzyme, superoxide dismutase, which neutralizes the superoxide, which is the major nitrous oxide destroyer, and catalase, which eliminates hydrogen peroxide, preventing fibrosis. Also, the mitochondrial metabolism is activated because when we heat the AMPK, which restores ATP balance, and the PGC1 alpha pathway, which regulates mitochondrial metabolism, also increases. So in the end, what we get is improved energetic, smooth muscle cells and endothelial cells, and in short, it restores cellular energy metabolism. Finally, we have indications for neural support because radiofrequency volumetric heating also induces heat stress protein 70, which is known to upregulate neurotrophic factors such as NGF and BDNF, brain-derived neurotrophic factor. BDNF is not only in the brain, it's very well abundant in the peripheral system as well as in the pelvic area. And what these factors do, they support cavernosal nerve survival, neuroprotection. They enhance the growth and differentiation of new neurons and synapses, neurogenesis, and it is vital for the communication between nerves and their target muscles or tissues, synaptic plasticity. So this is particularly relevant in diabetic patients and in post-prostatectomy patients. So now, with all these multifactorial pathways, it's not only structural. We're now not only addressing collagen and structure, we're addressing mitochondrial metabolism and antioxidant pathways and vessels as well, and we may also be addressing neural components. So if we look at post-radical prostatectomy, neuropraxia, which reduces nocturnal erections, leads to hypoxia, to fibrosis, and to shortening of the penis. If we can improve oxygenation, I think we're doing that very well, we're improving it early. if we can reduce fibrotic signaling, and we're doing that with heating, and if we can support nerve recovery, we might be able to preserve erectile function and improve tunical integrity during rehabilitation. So I believe that this is a very promising area for continuing studies and future studies. So if we look at all the effects of the radiofrequency therapy, at the beginning we get vasodilation, perfusion increases, oxygenation increases, NO is released, we get endothelial activation, we get muscle relaxation. All this happens during the first weeks of treatment. Then we have improved endothelial recovery, VGF increase, FGF2 activation, increased mitochondrial metabolic activity. And then at phase 3, we see the collagen remodeling, the extracellular matrix becoming competent and compliant. And this explains the early improvement that we see, as well as the early structural architecture of the tunica albuginea. And what you see here, what I showed you, is all the pathways just in one table. And just to understand everything, what we are doing, on one hand, we're reducing all the inflammatory, toxic environment that is around the tissue, which is either damaged in post-prostatectomy or either old, and we are doing some repair mechanism, the VGF, the FGF2, and the BDNF, and all the other factors are repair factors, together with the energy provided by the mitochondria. We're doing a lot of things in the penis. So we have to look at erectile dysfunction not only as we are seeing it today, a vascular event or a neurovascular event, but there are a lot of things going on to have erectile function. So in summary, since for decades we have focused on inflow, more recently we've explored signaling through regenerative therapies, radiofrequency therapy introduces a structural paradigm. It may have a direct heating effect, causing vasodilation and increased perfusion, improved oxygenation, and simultaneously smooth muscle cell relaxation, improve corpora cavernosa compliance, and with thermal signaling, RF can activate multiple endogenous pathways that block the toxic effect of the surrounding tissue and reduce oxidative stress, restore collagen architecture, and then we have a real change in the erectile function mechanism. So for me, the question is no longer whether ED has a structural component. Certainly it does. The question is if we, together as urologists and researchers, are we ready to treat it as such? Thank you very much.